Hello, my name is Cece Morris, and tonight I'll be presenting on hypothyroidism. So my case study is on Vicky, who's a 31-year-old African-American female who was seen in the endocrinology clinic today after being referred to the clinic by her OBGYN after she had some routine lab work done in her OBGYN office. Upon assessment today, Vicky reported that over the past 6 months, she has had increased fatigue. She also reported that she has more difficulty concentrating at work and she has gained a few pounds. Vicky also has noted that her periods are a little bit heavier than normal, are somewhat irregular, and she also reported that 2 years ago she attended a health fair where she had her blood work completed and her TSH level was within normal range, and at that point she did not require any follow-up. Now, a little bit of background on Vicky. Vicky has been married for 6 years. She's 31 years old with infertility, fatigue, other non-specific symptoms, and her husband at this point is contemplating in vitro fertilization. Now, based on the symptoms of elevated TSH, which is suggestive of hypothyroidism and a family history, one sister aged 32 who has hypothyroidism, her OBGYN felt that she needed to be assessed for hypothyroidism. Now, upon physical assessment of Vicky, she reported being fatigued, occasional insomnia, constipation relieved with Marilax, occasional headaches relieved with non-aspirin pain reliever, and also dry skin. Now, I want to look at Vicky's lab blood test results. If you looked on the left side in this middle column, you notice that her electrolytes and her hematology reports are normal. But let's go over here to her right side and focus on the lab result here on the right side. So look at her TSH. It is at a 9.8, a bit elevated. Her free T4 a 0.72, and that is okay. Her LDL is at a 142. We know that a normal LDL should be 100 or less, and that in normal people with no health issues, one between 100 and 129. Her HDL is okay, 45. And then down here at the bottom, we see that Vicky does have the marker, the anti-TPO antibodies for hypothyroidism. Now, if we look at this chart right here, it gives a clear outline of the correlation between thyroid disease and high cholesterol. Now, we talk about her LDL being elevated and also her TSH being elevated, which is under active thyroid gland. And this is why we see in her lab result looking that way. Now, look at Vicky's drug chart. Routine meds, she's taking iron, 300 milligrams daily, calcium carbonate, 500 milligrams daily. And we could say that these two medications are what contributing to her constipation. But then if we look closer at the pathophysiology of hypothyroidism, we know that it does slow down the process of the digestive system. So then that is one of the symptoms that patient will present with when they're experiencing hypothyroidism. We'll look at her PRN medication here on the right side, and she is taking Marilax for that constipation, which is good. Now, when I get into a little bit of teaching Vicky about her medication and what she needs to take daily, I want to go over her increasing that Marilax and at least taking it 3 to 4 days a week and increasing her fluid intake. And this will help her with her constipation issue. Now, hypothyroidism can be classified in different ways. There are different classes that you can put patients in based on the symptoms that they're presenting. Subclinical is where I would put Vicky at this time. And on the subclinical, we noticed that the patient could have a normal free T4 estimate and that the patient could have a TSH normal or below a 10. At this point, we know that Vicky is at a 9.8 and that her treatment plan will be specific to her. So again, 5% or more Americans will fall into this category of subclinical hypothyroidism. Vicky pharmaceutical plan, again, I list her subjective symptoms that she complained about while being seen in the clinic. So if you look at this closely, you can see most of the symptoms that she presented with. And then I'll talk about it a little bit more on the slides that we're moving forward with. Okay, so in hypothyroidism, we know that the definition is inadequate amount of thyroid hormone are released, and the thyroid gland stimulating the pituitary gland are releases more TSH. Because T4 regulates more essential functions of the heart, digestion, and mental retardation, insufficient supply of this hormone can slow life-sustaining process and cause damage to organs and tissue. Again, we're going to focus here on the digestion, and we can say yes, Vicky is having some digestion issue. She's having some colon issue with her constipation. Pharmaceutical care plan, again, we want to look at her symptoms and we want to look at how I'm going to address it in the next couple of slides. So in Vicky pharmaceutical care plan, I want to talk about how the diagnosis of hypothyroidism is done and what test is done to diagnose this disease. So serum TSH, it is the most sensitive test for diagnosing hypothyroidism, and serum T4 is the most useful for diagnosing primary hypothyroidism. So we know that Vicky had a TSH done, thyroid panel, and both these tests were included in that panel. Treatment overview. So the goal of the treatment for Vicky is to put her on a medication that is going to mimic the normal physiological function of the thyroid gland and alleviate the symptoms and signs that she's having right now. So again, the treatment should be tailored to Vicky's individual needs, and the treatment of choice at this time that I think would be beneficial for her would be the levothyroxine therapy. So with levothyroxine therapy, you always want to start with the lowest dose to prevent atrial fibrillation. Dose of LT4, you want to start at the 25 to 50 microgram per day. And then if we're treating elderly patient with this, we know that it will be a reduced dose because of heart disease. And then again, adjustment in dose is made in 12.5 to 25 microgram. TSH should be measured 6 to 8 weeks after starting treatment or after making adjustment to the dosage. The target TSH level for patients on these medications should be between 0.3 to 3.0. And then after achieving this a stable TSH level, then the patient should be seen annually and followed to make sure that TSH level is where it needed to be. It needs to be. So treatment prior to pregnancy, because this is one of Vicky's issue, and we know she's trying to get pregnant. Treatment with L-thyroxine should be considered, which is why I recommended that for her in women of childbearing age with serum TSH levels between 2.5 and the upper level of normal if they're planning to get pregnant or pregnant in the first trimester. So in a study that was done on the L-thyroxine treatment versus no treatment in hypothyroid mothers starting in the first trimester, the outcome showed that IQ of children tested between 3 years of age and 2 months and 3 years and 6 months, that there was the percentage of IQ was greater than 85% in children from treated mother versus non-treated mothers. And then again, treatment management for Vicky, I want to put P4 therapy based on the following findings: her increased TSH, her positive anti-thyroid antibodies, and then her dose would be started at 30 micrograms daily. She will be followed up in the office in 8 weeks. And then at that point, we'll do a thyroid panel just to see where she is. I also want to make sure that she continue taking her Marilax and increase her fluid intake, so that way we can look at her constipation issue and make sure that is also. Again, my name is CC Morris, and thank you for listening to my presentation.